Now I am showing you the structure of a cohort study. Who is he? क्या किया अभी? So in the last slide, I started with outcome plus outcome minus. But here I am starting with exposure plus exposure minus. Now you see, who is he? Now what I will do? So naturally you can understand the time period that will be required. Around 10 years or 20 years, they have to be followed up to see how many of them they develop lung cancer, how many of them they develop lung cancer. If I see lung cancer was more among this, then again I can say smoking causes lung cancer. If I see lung cancer less, then I can see smoking that causes lung cancer. Is it clear? Right? So this is the basic structure of the cohort study. So elements of a cohort study, you see selection of the study subjects. What I told you in case control study, selection of the cases and control. Selection of the disease plus, disease minus. But here we have started with selection of exposure plus and exposure minus, obtaining data on exposure, selection of comparison groups. We have to follow them up for a certain period of time, and then we'll do the final analysis. Now is my research question, first one, who will be the exposure positive, who will be the exposure negative? Is this clear now? Now it is cohort study. Now I am starting with OCP plus, OCP minus. Had it been case control study, MI plus, MI minus. Is it clear to all of you? This is the basic thing. Second one is current intrauterine device associated with pelvic inflammatory disease. So I will start with women, those who are using IUD, and the women, those who are not using IUD. I will follow them up for a certain period of time. Now you might ask me, sir, what is the meaning of certain period of time? How long I will follow them up? So it depends upon the literature. If literature says that continuous use of IUD for 5 years is enough to give rise to the pelvic inflammatory disease, then you have to continue the study for at least 5 years. So it depends upon the review of literature. It depends upon the present understanding of the science regarding the exposure and the disease. Clear? So in that way we will do the cohort study. So example of the cohort study, the Framingham heart study and oral contraceptive studies and health. So you see, these are some of the examples I have written. Obesity and the risk of stillbirth, a population-based cohort study. Can you tell me how they started the disease from the title? What is the starting point of the study? Very good. So they selected some women, pregnant women, those who are obese, and they simultaneously selected some pregnant women, those who are not obese. How did they define obese? Again, it has to be very much specific. They have to say either BMI less than 25 or BMI less than 30. So in that way, they have categorized the obese women and the non-obese women. Clear? And you see, this is very small period of study, around 9 months, because total pregnancy period is 9 months. So around 9 months or 10 months or maximum 1 year it will take to do the analysis, right? So in that way, so that depends upon the time period, how long you will follow up. It will again depend upon the specific topic and the present understanding of the knowledge. Can you tell me what is the starting point in this case? So they have categorized some women, you see again women. So women who are continuously they drink green tea and the women who do not use the green tea. And they followed them up for a certain period of time and they saw how many of them they develop colorectal cancer and how many of them they develop the colorectal cancer. So what is the analysis of the cohort study? The analysis is disease rate among exposed and non-exposed. Just see, it is just the reverse what we discussed in the case control study. Just reverse, isn't it? Do you remember? In case control study, we started with cases and control. We were interested to see the exposure rate among case, exposure rate among controls. But here you see, just the reverse. Disease rate among exposed and the disease rate among non-exposed. Now it will be a row percentage instead of the column percentage. Right? If your table is like this thing. So now you see in this example, out of 741 study participants, 204 were smoker. Out of 204, 64 developed lung cancer. Out of 537, 27 they developed lung cancer. So you have to calculate the percentage. You have to see disease rate among the smoker and among the non-smoker. So 64 by 204, 27 by 537 percentage, and similarly you do the chi-square test, what we did in the case control study. And second analysis is the calculation of the relative risk. Please remember, in cohort study, the final output is AIR. A stands for attributable risk, I stands for incidence, and R stands for the relative risk. So this is the mnemonic of what we can calculate from the cohort study. AIR. A stands for the attributable risk. You see, this is the attributable risk. I stands for the incidence, and R stands for the relative risk. And how do we calculate the relative risk? So please remember, you see, incidence of the disease among exposed, 64 by 204, divided by incidence of the disease among non-exposed, 27 by 537. And we have got the relative risk is 6.23. It is same interpretation like what we did in the case of the odds ratio. More than one, it is positively related with the disease. Clear? And next, we calculated the attributable risk. How it has come? 313, 50. Do you know the formula of attributable risk? You write it down. Incidence of disease rate among exposed. Incidence of disease rate among exposed minus incidence of disease rate among non-exposed divided by incidence of disease rate among exposed. Incidence of disease rate among exposed minus incidence of disease rate among non-exposed divided by incidence of disease rate among exposed. How 313 has come? Incidence of disease rate among exposed. Among exposed is 204. How many of them they develop disease? 64. Probably you see, calculate 64 by 204 into 1000. Probably it is coming 313. Just check. And another one, check incidence of disease rate among non-exposed. 27 divided by 537 into 1000 multiplied by 1000. Alright, 313. So in that case we have got 313. So 313 minus 50 divided by 313 into 100. Since into 100, that is why I showed you attributable risk is an example of proportion. Do you remember I told you? AR is an example of proportion because multiplied by 100. So it has come 84%. Is this clear? So please remember, these three type of analysis we do in the cohort study. We see the incidence among exposed and non-exposed. We calculate the relative risk, incidence of disease among exposed by incidence of disease among non-exposed. And thirdly, we calculate the attributable risk, incidence of disease rate among exposed minus incidence of disease rate among non-exposed by incidence of disease rate among exposed. Now, can anybody tell me what is the difference between the relative risk and the attributable risk? Relative risk is more important in case of etiological inquiry. When I say it is more than one, we say a positive association or causation of the disease. But what is the meaning of the attributable risk? Public health specialists, they are more interested with the attributable risk compared to the relative risk. Because I am least interested to know smoking causes how much increase all this thing. I am interested to know if I cut down smoking, if I eliminate smoking from the community, then I can save 80% of the lung cancer patients that are arising out from the smoking. So public health specialists, they are more fond of having attributable risk compared to the relative risk. So relative risk is for the etiological inquiry and attributable risk is from the public health perspective to see if the susceptible factors can be cut down or it can be eliminated. How much of the disease I can cut down in the community? That I am interested to know. So that is expressed from the attributable risk. Is this clear? So this is how we calculate the basic calculation from the cohort study. Is this okay? Good. So interpretation of the relative risk, you see, relative risk just like a cohort, just like a odds ratio. Relative risk less than 1, exposure negatively related to the disease. RR equals to 1, not related, more than 1, positively related. RR 2 times higher among the exposed. This is how we interpret the relative risk in the cohort study. So please remember one important thing, incidence. So from cohort study, what we can calculate? We calculate AIR. A stands for attributable risk, I stands for incidence, R stands for the relative risk. Plus, please remember from case control study, we cannot calculate prevalence because we start with the disease positive and disease negative. So prevalence cannot be calculated from the case control study, but incidence can be calculated from the cohort study. Is this clear? And I told you, if you remember, incidence can be only calculated from the longitudinal design when there are follow-up. And I have told you, this is a type of follow-up. We started with smoker, we started with non-smoker, and we followed them up for a considerable period of time. How long? That depends upon my specific topic, specific understanding. And then at the end we saw how many of them they develop disease and how many of them they don't develop the disease. And now we are comparing between these two. This is the basic structure of the cohort study. There are two special types of cohort study. I just forgot, there are two types of cohort study. One is the concurrent parallel study and another one is the retrospective cohort study. Do you know, or I will tell? One is concurrent cohort study, means parallel cohort study means exposure is just going on and I will follow them up after 10 years or 15 years. This is prospective cohort study. And one is the retrospective cohort study. Retrospective cohort study is similar in nature in case of case control study where both exposure and outcome both have occurred. But my approach of analysis is from exposure to this thing. So that is why now we call it as a historical control, something like this thing. We take some historical data and we follow them up. So this is the retrospective cohort study. Sometimes it is mixed. Suppose I have started one study, I am looking at one register for the last 5 years. From the last 5 years I have come here, 2023. Now 2023 I will do for 2027. So retrospective, now onwards prospective, so it has become a combined cohort study. So it might be like this thing. So another two different types of cohort study design is there. I'm not going into detail, very rarely used, but very interesting to know. One is the nested case control study, one is the case cohort study. From the name, it seems to be a case control study. But please remember, this is actually a cohort study. So both Nested case control study and case cohort study, these are nothing but some advanced features of some other cohort studies design. What is that? I'm just telling you in one statement, then all of you will understand. Say for example, I am following some neonates, some newborn babies. Some newborns, those who were born in the gynae obs department in this hospital, they are being followed up for 6 weeks. Now I have seen, so in that way I have gathered around 50 newborn babies. Now out of 50 newborn babies, I have seen after 1 week, one baby has unfortunately died. So I have taken that baby as a case. And on that point, one baby who was alive, based upon age and sex, that baby will be taken as control. So again, I will follow them up. After another week, 2 babies have died. 2 babies will become cases. So total 3 cases. And 2 babies will be taken as the control. So this is basically the nested case control study. Is this okay? So this is basically the nested case control study. And another one is the case cohort study. It is similar like a nested case control study when we follow them up for a certain period of time. But what I told you in the nested case control study, after 1 week, one newborn has died. At the same time, I have taken one control. But here, in case cohort study, at the same point, I do not take a control. Instead, I follow them up. I see out of 6 weeks, how many newborn they have died. Say, for example, 6 newborn have died. And out of the rest of the cohort, I will select 6 controls. So this is case cohort study. Is this clear? So there are 2 types of designs of the nested case control study and case cohort study. But please remember, these are nothing but a cohort study. Am I boring you too much? I want some honest answer. खूब ज़्यादा बोर तो नहीं कर रहे? ठीक है. So we are having another 30 minutes, ना आशीष sir? ठीक है ना और 30 minutes? बस. So you can have some water as well. So many things are there. I have tried my level best to make it as simple as possible so that all of you understand. If you go through the book, if you go through the literature, everything you will get. But basic conception that is very much mandatory, right? So if you build up the conception, then on that conception you can build up of so many things, right? So this is the thing. So the next type of study design we are coming as the experimental study. You see, we have written 4 types of experimental studies. One is the randomized control trials, also known as the clinical trial. You see, individuals, they are the unit of study. If we talk about the cluster randomized control trials, different groups are the unit of studies. If we talk about the field trials, see, healthy people are the study. Now you might argue, sir, you are taking some healthy people in your study. Is it not the violation of human rights? But I am telling you, these healthy people are taken for a good thing. We are administering some vaccines so that they are at risk of developing the disease. But ultimately we will see how many of them they develop the disease in question. So in that way, I have recruited some of the healthy people as well. So this is known as the field trial. And if you include some communities, they are known as the community trial. So now I am starting with so in one group, there will be one intervention, right? And in another group, there will be no intervention. That is why it is intervention study. Now you see, I have used this slide for the first time now. Up to that, so many studies I have talked about. I did not write anything about intervention plus, intervention minus, because all these studies were descriptive studies, analytical studies. But now onwards, I am writing intervention plus and intervention minus. So intentionally, I am giving some intervention, or intentionally, I am not giving some intervention. Some issues, ethical considerations, No patient should be denied appropriate treatment. It must be acceptable in the light of current knowledge. That is also very another issue. Sir, if you think that this vaccine will improve everything, then why you are so crude? You are giving vaccine to only one group and you are denying the vaccine in another group. Then I can say, yes, that is not proved. I think that it will be good. So I will see the efficacy or effectiveness. If I see good, then and then they will also be given vaccine. So in that way you have to justify. When we are doing one research, you see 4 basic principles it has to be maintained. I think all of you know. What is that? First one is the autonomy. I have come to your hospital. Now you are recruiting me jabardasti. Sir, you have visited my hospital. You have to take part in my study. अरे मेरे को एक पेशेंट ही चाहिए सर, आप आ जाइए ना तो हो जाएगा मेरा स्टडी. क्यों ऐसा कर रहे? मेरे से हॉस्पिटल से ला रहे, मेरा डॉक्टर को बुला रहे, मेरे से दवा ले रहे, और आप हो गया तो मेरा स्टडी खत्म हो जाएगा. अरे भाई आई एम नॉट इंटरेस्टेड. नहीं ना, आपको चलना पड़े तो आप जबरदस्ती पकड़ के ले जा रहे हो. ठीक है? सो इट कैन नॉट बी लाइक दिस थिंग. सो ऑटोनॉमी मस्ट बी मेंटेन्ड. Right. So how autonomy is maintained? So this is the answer. What madam has said. Informed consent document. I have signed. कैसे sign किया है? It may be signed like this thing. Hey, sign करो. Then another way, ma'am, we are doing one study, so you are interested. She might sign, might not. Nowadays in Western countries, they are doing this thing in the video. The way I have taken the signature, I say, now I have totally explained on this thing. So this is the going on, right? So autonomy has to be maintained. So it is not under jabardasti, forcibly you cannot recruit some patients in your study. अरे सर एक ही patient चाहिए आप आगे तो बहुत अच्छा हुआ. अरे क्यों ऐसा कर रहे हैं आप? So I cannot be like this thing. So please remember. So autonomy is the first one. Second, 2 important principle is the beneficence. Beneficence means whatever I will do, it will do some good things. So second principle is the beneficence. What is the third one is the non-maleficence. Non-maleficence means if I am unable to do any good things, I will not do any harm to the patients. This is non-maleficence. What are the different types of harm? I have requested her, सुनो मेरा एक ही पेशेंट है थीसिस का, तुम आ जाओ, you are fitting everything, so your age group, this thing, and I am doing this thing to study. तो बोला नहीं सर, क्यों नहीं, चलो. So then जबरदस्ती I have recruited. Say for example, I have recruited some patient as well. Then the patient is saying, sir, तो मेरा तो रोज चला जाएगा sir, I'm working as a labor. अरे चलो तुम करो काम. So I have done some financial losses. That might be like this thing. Or during blood collection, I am a novice. I have punctured so many times for taking blood. This is also physical harm. And that harm, that what I told you, that is a financial harm. And say for example, some patients have come and then I am asking some questions on during the COVID-19 period, whether they have lost some near one or dear ones. And now some patients, they have broken down. Sir, I have lost my mother, I have lost my so many close friends, and now they are crying. These are psychological harm. So many different types of harms are there. So whenever you are doing a research, so all these things will be taken into consideration. So autonomy, beneficence, non-maleficence. Next one is the confidentiality. So whatever I have gathered the data, I have to ensure each and every participant, this is only doing for my analysis. I will not show in my thesis, yes, patient X ye bola tha. No, it will come as a grouped mean data or this much cured, this much not cured, in that way. So everything will be secured and the data will not be disclosed anywhere. It should only be doing for the research only. And last one is the justice. What is justice? Fair inclusion of the participants. So हम देखे हैं तो वो पे जो तो prison है उसमें कुछ murderer है, कुछ चोरी जो किए थे उसको है, तो उसको लाके मैंने एक clinical trials चालू कर दिया. Is it good? Because after some time they will be hanged. Then is it good or fair to recruit them as my study participants? No. So this is known as the justice. This is known as the justice. So fairness should prevail in recruitment of the study participants. So please remember these 5 basic principles of ethics. One is the autonomy. second one is the beneficence, third one is the non-maleficence, fourth one is the confidentiality, and fifth one is the justice. Right? So these are the things that you have to take into consideration. So no patient should be denied appropriate treatment. It must be acceptable in the light of the current knowledge. And this is basically the expression of autonomy, informed written consent, what we have or not. What I told you in field trials, who are the participants? Healthy individuals. Then you might argue, sir, healthy individuals, you are giving them some intervention. But you see, they are disease free. Yes, as on today, they are disease free. But at the same time, they are at risk of acquiring the disease or having the disease. That is why I am now doing the trial. So that these people will be protected in future. Salk vaccine for the prevention of poliomyelitis involved over 1 million children. Again, you can think about the COVID vaccine trial. Do you remember? This is also example of a field trial.